Hello, everyone. Welcome to Preemie Chats. Thank you for joining us here today. I am Leah Whitehead. I am a preemie mom and a volunteer with the Canadian Premature Babies Foundation. The Canadian Premature Babies Foundation is also known as CPBF, and it is a charitable organization. And its mission is to support and educate Canadian families of premature babies. This Preemie Chat series is just one of the many ways that they do that, and they share information with NICU families and healthcare professionals. Here, every Friday, we talk with medical professionals, researchers, and the experts, the parents who share their NICU experience and knowledge. And we want you to be part of the discussion too. So this is a pre-recorded session, but please, you can still reach out to us and leave comments or reach out to our guest today with any questions you have. Be sure that you check out CPBF's website. It is there on the screen, canadianpreemies.org, where you can find all kinds of resources and support. Parents are the most important people and intervention a baby can have in NICU, but we know that NICU itself can be very disorienting, especially when you first arrive. So on this website, you'll find resources like the new video series, Welcome to the NICU, that hopefully will make you feel like you know just a little bit more about the NICU and your invaluable role there. And right now, in the face of the fears and anxiety brought on by the COVID-19 pandemic, CPBF put together a parent care program, and they offer 4 therapy sessions for families currently in NICU or those who have been discharged up to 3 years. To apply for the parent care program and watch the videos, visit the CPBF website. Let's get to today's topic. And this one is pretty close to my heart because I actually was part of some of this research. Right from the time an extremely preterm baby is born, a lot of critical medical decisions are made that may have lifelong impacts on the child and their family. And some of these decisions are in the form of standardized NICU guidelines, while others are individualized medical decisions and they're made at the bedside. The care that families are actively involved in are often limited to low-risk practices. And parents are generally seldom involved when it comes to making critical decisions that have significant benefits as well as potential harms. The balance of such benefits and harms are left exclusively to the medical teams as they require careful appraisal of research evidence. However, the very concept of evidence-based medicine is incomplete without incorporating family values and preferences. So in this session of Preemie Chats, we will get a sneak peek at how family values and preferences can be systematically incorporated into critical medical decisions in the NICU. And to discuss this, I'm very happy to be joined today by Dr. Souvik Mitra. Dr. Mitra is a neonatologist and associate professor of pediatrics at Dalhousie University and at IWK Health in Halifax, Nova Scotia. His primary research interests revolve around improving patient and family important clinical outcomes of extremely preterm babies with a patent ductus arteriosus, or as I know it, PDA. He is involved in many national research projects and is active on various national committees, and we're really excited to have you here today. Welcome, Souvik.
Thank you, Leah, for that introduction, and delighted to be back on this platform to talk about something very, very close to my heart as well. That is making family-centered, evidence-based clinical decisions, especially focusing on incorporating family preferences in critical decision-making. I have no conflicts of interest to disclose. So starting off with the obvious, what do we mean by patient and family-centered care? The Institute of Patient and Family-Centered Care has defined this process as one where we work with patients and families to co-create decisions and plans rather than just doing it to or for them. And over the past few years, this approach has been adopted all across, especially in this part of the world, in neonatal intensive care. But one limitation that we don't often talk about is the fact that this approach has largely been limited to care practices that are low risk, such as feeding practices, skin-to-skin care, and similar other practices when babies are relatively stable. But a lot of other decisions have been made well before a baby reaches to that point. And when it comes to those critical medical decisions, for some reason, this philosophy completely goes out of the window because a clinician or a resident or a nurse practitioner walks into the room and says that we will give this drug to your baby to protect your baby's brain, or we will give this drug to protect your baby's lungs, or we routinely start antibiotics here because it is our standard NICU policy based on evidence. And this has created this perception of evidence-based care where people feel that it is a group of doctors who come together, sit down, discuss the evidence, and then come up with this standard NICU policy. And once this policy is made, it is written in stone and there is no room for any deviation or individualization. Well, in all fairness, there are certain merits to this process. In this modern world where medicine is being increasingly delivered by complex healthcare teams, there is a risk of practice variation. And what standardization helps us to do is not only reduce the practice variation, but improve efficiency, which in turn improves patient safety and care quality, thus making healthcare more cost-effective, and in the process, improve clinical outcomes that at least we as the healthcare providers think are important. But the question that we have failed to critically ask is all practice variation bad? And that's why we need to take a very close look at this phrase practice variation. Because what we really want to achieve is cut down on unwarranted clinical variation through standardization. And by unwarranted clinical variation, we mean variation that is based on unjustified deviation from evidence, variation that stems from differences in the physician's needs and preferences or their lack of expertise. While we should aim for some degree of flexibility or warranted clinical variation, where the variation is based on the family's needs and preferences, or the local context, such as the socio-demographic and cultural background of the region. And this philosophy of cutting down on unwarranted clinical variation and promoting some degree of warranted clinical variation conforms to the true essence of practice of evidence-based medicine, which has been defined as the explicit and judicious use of current best evidence in conjunction with clinical judgment and patient values and preferences. So until and unless we incorporate all these three pillars together, we are not, unfortunately, practicing evidence-based medicine. Therefore, evidence-based medicine is not just the practice of best research evidence. It is a combination of doing the right thing based on evidence and also doing it right in the local context, while taking into account the preferences and values of families to come to family-centered evidence-based decisions. And that's why this pillar of family values and preferences are so important in the practice of evidence-based medicine. So how how do we define family values and preferences? They specifically refer to the perspectives, beliefs, expectations, and goals for health and life of the parents for their infants, and to the processes that families use in balancing the potential benefits and harms of all the different treatment options that are available. And why are they important in this field? We'll just talk about an example from a recent guideline development project that Leah and I were part of to kind of explain the reason why. So the question was, out of other questions, should this drug called indomethacin be given right at birth in extremely preterm infants to prevent complications related to a patent ductus arteriosus or a PDA? Now, we all know that this condition called the PDA is unique because in some babies, it does not cause any problems. This little blood vessel closes off on its own. But in some other babies, it may cause some serious problems. So the question is that, should we give this drug right at birth to all extremely preterm babies without the knowledge of whether there is a PDA or not to root this problem out right at birth? There is some evidence that giving indomethacin right at birth may reduce severe bleeding in the brain. There is controversial evidence on what impact indomethacin has on the lungs. While again, there is some low quality evidence that suggests that indomethacin does not really go well with the gut. It adversely affects the gut. So as you can see, there is quite a bit of variation on the effect of this drug on different outcomes. And therefore, there is quite a bit of variation in the use of this drug across Canadian NICUs, with only 16 out of the 32 CNN sites currently use indomethacin prophylactically, which means that giving the drug right at birth within the first 24 hours in extremely preterm babies without the knowledge of whether the PDA is there or not. Now, one may wonder that why do clinicians differ so much in their opinion when there is some evidence on the effect of this drug on these different outcomes? Well, there could be several reasons. First, the clinicians may not be up to date on recent evidence. Second, the evidence may not apply to their local context. Or we may not have a good understanding of all the statistical jargon that is written in all these papers. But say, for example, we are up to date on recent evidence and it applies to my local context, and I do understand what I'm reading. Even then, these interventions or these drugs have different effects on different outcomes. And what's important to one clinician may be very different to what's important to another clinician. And that's why decisions unfortunately end up being based on how we as clinicians value outcomes in our local context without even having the knowledge of what's important to the families. Now, it is easier said than done on how to incorporate family values in the NICU because there are certain issues that are unique in the NICU setting. For example, who defines the child's best interest and the ethical complexity around this question, which is again a completely different topic which needs a whole session on its own altogether. Second, we need to understand that the NICU is a very, very stressful environment, especially in the first few hours after birth, and the parents may not have the bandwidth to fully comprehend the short and long-term impacts of their child's current clinical condition. And therefore, there is always this risk of information overload in this already stressful environment. We cannot just go up to the families every few minutes to say that, hey, we need to make another decision. So we need to decide on which decisions should involve the families and which decisions should not. And therefore, there are certain unique advantages of having parent preferences included in every guideline. One, the need for shared decision making is highlighted whenever it's possible. And in situations where it is not possible, such as giving surfactant right at birth, even then the views of a representative sample of parents have already been considered, thus making the decision as evidence-based and family-centered as possible. So how do we go about it is a big question. There is this methodology called GRADE, which stands for Grading of Recommendations, Assessment, Development, and Evaluation, which has been widely used for years to rate the quality of the scientific evidence to make decisions, both in the adult medicine and also in neonatology. But many of us may be unaware that GRADE also offers a transparent and structured process for developing clinical practice guideline recommendations using their evidence to decision framework, which puts together all the different pillars of evidence-based medicine. So this evidence to decision framework consists of these criteria as listed in this table, and what the guideline panel has to do is provide their judgment on each of these criteria. And what that process enables us to do is not only consider the best available research evidence, but also helps us to combine that with family values and the local context, such as resources required, cost effectiveness, issues around equity, acceptability, and feasibility of the intervention, to come to the final strength and direction of the recommendation, which can be any one of four options: either a strong recommendation for or against an intervention where the benefits clearly outweigh the risks, and those are in perfect alignment with family values and also feasible and acceptable in the local context. But in a lot of situations, the recommendations are weak for or against intervention where the benefits or harms do not clearly outweigh each other, or there is a bit of variation in how families value different outcomes. So what the process of family involvement does is that it makes this entire process fair and transparent, and also makes sure that we have considered all important outcomes for decision making before we even put together the evidence and critically appraise the evidence. So coming back to our example of giving indomethacin right at birth in extremely preterm babies, what we did right at the outset was to create a guideline panel that not only included healthcare professionals from different backgrounds, but we ensured that a third of the panel were either parents of extremely preterm infants or adults who were themselves born extremely preterm. We then ensured that none of them had any financial or intellectual conflicts of interest that could affect their judgments. And then we did a preliminary survey of the panelists to find out what outcomes were really important, and that would guide our decision making. So once that exercise was done, we then went on to synthesize the evidence on the Cochrane neonatal platform, and we just published this paper earlier this year in April. And that was just the first part. Then we had to figure out what the parents felt about this evidence. So we then designed a cross-sectional semi-structured mixed method study where we enrolled not only adults born very preterm, but also families of very preterm infants from across Canada and the United Kingdom. And a big thank you to the Canadian Premature Babies Foundation for actively helping us recruit families in this process. We conducted the study in 2 phases, a very important pilot feasibility study that gave us the opportunity to learn from and modify the interview as required before we moved on to the formal values and preferences study, where we included a total of 40 participants, majority of whom were parents of extremely preterm infants, along with 9 adults who were born extremely preterm, with an overall median gestation age of only 26 weeks. So as you can imagine, all of them have had lived experience of all the complications that an extremely preterm baby would go through in the NICU. Now, what this process helps us to do is first understand the value placed on critical outcomes by families, and that helps the guideline panel to select what outcomes to look at when balancing the benefits and harms of the intervention. And then it helps us to explore the preferences of the families for or against an intervention based on their understanding of the evidence. And that information is incredibly helpful for the panel to decide not only on the strength, but also the direction of the final recommendation. So based on the feedback from the pilot study, in the formal values and preferences study, we asked the participants to rate these 5 outcomes, that is death, severe brain bleeding, chronic lung disease, necrotizing enterocolitis, and PDA, on a scale of 0 to 100, 0 being least severe and 100 being the most severe. Now, not surprisingly, death was rated as the most serious outcome, followed by severe brain bleeding. And interestingly, chronic lung disease, which features as the most common primary outcome in most neonatal clinical trials, was actually rated down quite a bit in seriousness by the families. After that, we then moved on to eliciting the treatment preferences when presented with the evidence on the benefits and harms on these outcomes. And we did that using these infographics where we presented the families with evidence on how much an outcome will be worsened or improved per 1,000, with a range of uncertainty, because every research is different, and some research makes us more certain about an effect, and some research is, for various reasons, gives us less certainty about the effect that we are seeing from the results of that research. So we presented with all of that evidence and then asked the families that based on this, whether they would have chosen this medication for their child. And then we repeated that process for the different drugs. So for indomethacin, we found that majority, 90% of the participants would choose this drug for their child. And the most common reasons for choosing that was reduction in the critical outcome of death and severe brain bleeding. They felt that the possible increase in chronic lung disease was less worrisome. And overall, there was a higher certainty in evidence for benefit. And there was a lower certainty in evidence for harm. Now, if you recall, this was very different from the clinicians' preferences, where only 16 out of the 32 sites in Canada are currently using prophylactic indomethacin, which is very, very interesting. So now, with this updated knowledge of how the parents feel about this evidence, we then reconvened our guideline panel to move from the research evidence to making a clinical judgment, where The guideline panel, as I said, had to provide their judgment on each of these clinical criteria as applicable. So just to give you an example how this process worked, the guideline panel was provided with the research evidence, say, on the balance of effects, and there was a discussion around that research evidence which brought about some additional considerations, and then the panel voted on which drug was the best, which drug was the worst, and so on and so forth. And this exercise is then repeated with each and every criterion. So for indomethacin, we found that overall there was moderate certainty that this drug could reduce death by 24 per thousand. This drug could reduce severe brain bleeds by 43 per thousand, and we're again moderately certain. Low certainty to suggest that indomethacin could slightly worsen chronic lung disease, while we were fairly certain, at least from randomized controlled trials, that it did not affect the gut as much as we would have expected. So to visually look at this evidence, this is how it looks like. So the line in the center is the line of no effect. Anything to the left is benefit with the drug. Anything to the right of this vertical line is harm with the drug. So we find that with indomethacin, there seems to be a definite benefit in terms of reduction in severe IVH, that is brain bleeds. There seems to be a modest benefit with deaths, but we are a bit uncertain about it. There seems to be a slight benefit in terms of neck, and there seems to be slight harm in terms of chronic lung disease. So when all of that was carefully considered by all the panel members, overall, the panel felt that there was a definite reduction in severe IVH, a probable reduction in death, and in conjunction with that, there was a strong parental preference for use, with 90% of the parents preferring the drug. And therefore, that tipped the scale slightly in favor of using the drug versus that slightly increased risk of chronic lung disease. And therefore, after a lot of discussion, the panel provided a weak recommendation in favor of using this drug in extremely preterm babies who are at the highest risk of severe brain bleeds, while emphasizing shared decision-making with the parents whenever possible to evaluate their values and preferences. Because for a lot of families, this slight reduction in death and severe brain bleeds may not be sufficient enough for them to go ahead and expose their child to this drug. And this is so very critical because in a lot of centers, or in fact, in most centers, we at this point do not go through this process of involving families in deciding on whether to use indomethacin or not. So to end, evidence-based clinical decisions are influenced not only by the best available evidence, but also the local clinical context and the values of policymakers, which should not only include care providers, but also the parents. So how can we possibly ensure that family voices are heard in clinical decision making? Well, to begin with, we need to involve patients and family representatives in clinical research, because until and unless we know what's important to the families, we won't be able to generate evidence on those outcomes. Then we can evaluate their values and preferences on the different outcomes of importance. Then we should make every effort to involve them in guideline panels and policy making panels, and that helps in two ways. For recommendations that come out as weak and that are driven by variation in family values, that process mandates shared decision making by the care teams, and therefore introducing that concept of warranted clinical variation or individualization of care. While for decisions where there is a clear benefit or a clear harm from the evidence and there is minimal variation in family values, and also the family representatives in the panel all agree, then in those cases, you don't necessarily have to involve the families, and you can confidently go ahead and develop your NICU policy and standardize this as a guideline. And thereby, you know that even without involving the parents and burdening them with information, you have made an evidence-based, family-centered decision. So thank you, and I'll be happy to take any questions and discuss further with Leah. Thank you.
Thank you so much for sharing that with us. It is an incredible presentation, and I wish that we weren't pre-recorded because I would love to hear people's comments and questions on this one. But I certainly have questions, and you know that I do because we often discuss this topic together. And so my first question is, why do you think that already the values of healthcare providers and families don't align?
I think, there could be several reasons. One, and I think the most important is lived experience. I mean, my experience as a healthcare provider is one from taking care of a critically ill child in the NICU, dealing with all the complications in the NICU, and then beyond that, reading about the effect of those outcomes on an average over lots of like when I say on an average, when we read these papers on long-term outcomes, we see that investigators have followed up 500,000 preterm babies, and on an average, these are the outcomes. So that does not reflect the individual experiences of families, and I think that's where some of the disconnect comes. Second, sometimes we get hung up on important things, important outcomes that are important in the shorter term, but over time their importance decreases and they become less and less important. And the best example is chronic lung disease. You've been in the NICU, you know that it is such an important topic, like ventilation changes, fluid management, feeding, treatment of a PDA or not, giving steroids or not. So much of the discussion happens around chronic lung disease. But when I talk to adults who were born extremely preterm, they had rated it down way lower in their list because they felt that, yes, it was important maybe for you, but over the course of time, that was not the most important outcome for my parents or for me. So those are some of the important things that probably creates that difference. And that's why it's important to have parents on the table, because if a decision is made, say, solely on from the perspective of those short-term outcomes, the recommendations could be very different.
I have concerns about this only in that I love what you said about bandwidth of like families may not have the bandwidth to take in all the information and then make a decision. That makes sense. But I'm wondering, how do we implement this kind of standardization relationally so that if people do want that information and do want to make the decision and not have it based on this panel, how do we balance that? And when do we make those decisions?
Yeah, that's a very good question. And that's probably the key issue that we need to work on over the next little bit. For me, I think what this process has taught me is that the least we can do is offer a discussion to the families. And what we found from the study that we did is about half of the families, and we asked this question to the families that do you want to be involved for a decision like this? So 55% of the families said that, yes, I want to know about the benefits and harms of the drug, but at the end, I will leave it to you to make a decision, but I still want to know. 35% said that, no, I would want to actively be involved. I want to be involved in the decision-making process, know about the benefits and harms, and engage in a shared decision-making process. So what that tells me is that, yes, families are concerned about being overwhelmed with a lot of information in the first 12, 24 hours, but 90% would, like 55 plus 35, 90% would want to know. And therefore, that tells me that it is my duty to offer the discussion, that you want to have a discussion. There, we need to make a decision about this drug, which has some potential benefits, may have some harms. If you do not want to make engage in this discussion, that is fine. Based on a structured process that had involved families like you, our policy is to go ahead and give this drug, but one of the recommendations from that guideline was to have a discussion, and that's why I'm approaching you. But if you're feeling overwhelmed, it's perfectly fine. We do not have to have the discussion. As per our policy, we'll go ahead and give it, or not give it based on what the policy is. But I think that should be the approach.
When we look to the future of this, because I love the whole idea behind involving families on the panel, will this be that similar process for every guideline? Will we have to be soliciting a number of families to get their opinion every time? And do we have kind of a benchmark of when we go, okay, we've received enough family feedback that we feel confident in saying this is the family voice?
So to answer your first question, I think every decision, every guideline should have families involved. No question about it. Do we need to involve the parents in the NICU for every decision making? No, because as we have discussed, it is overwhelming. And that is why it is important to involve families in developing the guidelines, because that is where we can identify which decisions should involve families in the NICU. Because say, for example, giving surfactant, if we're creating a guideline on giving surfactant, I'm pretty sure at the end of the process, it'll be a strong recommendation in favor of giving surfactant, which means that, okay, you don't have to involve families in the process of deciding whether to give surfactant or not. So families should be involved. Now, the second part of the question, if families need to be involved in every guideline, do we need to go through this process of evaluating the values and preferences for every guideline? Well, we need to do more work on this because there's a bit of variation in opinion. One could argue that you could do a large study of families from different socio-demographic, cultural, educational backgrounds to figure out what outcomes are important to them, what is really important to them, and then you can tease out those subtle differences between cultures, races, so that you can really make individualized decisions, and you do not have to reinvent the wheel every time. On the flip side, there is some evidence from the adult world that, like where they showed that patients value outcomes differently in the context of different interventions. Does that translate into neonatal medicine? We don't know. I don't know. We have to do more work on that. But as a start, what we can definitely do is partner with organizations such as Canadian Premature Babies Foundation, where we can almost automate the process where if we are developing a guideline, we can kind of create an online survey where parents can voluntarily come in. It'll be a self-explanatory 5-minute, 10-minute survey where we are evaluating what's important to you in the context of this intervention, because it'll be very helpful because those parents have lived through that experience. So they understand the short-term complications, the long-term consequences of what we're talking about. And then this process won't be as tedious. So as we go along, I think the process will be much faster. And that's where partnering with Canadian Premature Babies Foundation and other such organizations is very, very helpful.
How has the feedback been as people hear of you doing this project from both families and healthcare providers? How have people been feeling about it?
So there is, there are mixed reactions. One, I see excitement amongst families, because up until now, as I said, that families were involved, like when we talk about critical decision making, families were involved in decisions around withholding or withdrawing care at the limits of viability. And then there's a huge gap, and then families are again involved when babies are relatively stable, and then we're talking about feeding, gavage versus other things, and skin to skin care and all of that. But a lot of things happen in between which have important impacts on the families, on the baby's health, where the families are not involved. And now families see that, yes, there is a structured process where I can be involved. So there is excitement. There is some concern, which we've already discussed, the concern around information overload. And that's why we need to do more work to kind of select which are the decisions where we should involve families. And even then, whether we should, when we've identified that these decisions should involve families, does that automatically mean that we dump the information on the families and drag them into a decision making when they're absolutely not ready? So the recommendation as of now is, or the consensus as of now is that, as I said, offer a discussion and engage them only when they're ready. If not, then go with whatever your guideline says, knowing that that guideline was made not only by a group of healthcare professionals, but it also involved family representatives.
Now, you had said that this was a topic that's close to your heart. So why is that? Why is this a topic that you're passionate about?
Yeah, so again, it comes down to decision making for the benefit of patients and families. And this topic kind of goes right down to the core of that philosophy of what we are doing is for the benefit of patients and families. And that's why it is so close to my heart. And the second is that it is directly linked to the true meaning of practice of evidence-based medicine, because all of my work is around better use of evidence and evidence-based practice. And I see this huge disconnect and misunderstanding of the concept of evidence-based medicine, as I just discussed earlier in my presentation, because amongst us healthcare providers, there is this misconception that evidence-based medicine is just practicing or implementing the best research evidence, regardless of what the local situation is or what the family situation is. And it is not that black and white. It is a shade of gray, at least for most interventions, where you have to bring in the clinical context and the family values. And that has been the core teaching of evidence-based medicine. So this project brings this right back in our field, and that makes it so exciting for me.
Well, thank you so much for joining me here today and for answering all of my questions and for your continued research in this area. I think it is amazing, and I am really excited to see where it goes and how this even starts discussions about what decisions should be shared, which I think should be all of them. So thank you for joining us here today. Do you have anything you want to add?
No, I think I just wanted to again thank you for having me back on the platform, and I'm really looking forward to questions from families because, as I said, that I've seen a lot of excitement from the families I've interacted with during the course of this project. So I'm really looking forward to how we can go forward. What are the challenges that families uh, foresee, which I haven't thought about because, as I said, this is a very, very novel thing that we are working on. There will be challenges. There will be things that we'll have to modify and work on. So I'm really looking forward to feedback, questions, comments, so that we can work on and try and make this a success.
Thank you so much.
Thanks, Leah.
And for everyone watching here today, thank you for joining us. The video of today's session and all the videos from this live series are available on the CPBF website. Again, that's CanadianPreemies.org. CPBF is a charitable organization that believes that through education and support, families will be empowered and ready to care for their baby. Visit their website and consider making a donation. Together, we can create a brighter future for all of our families. We will see you again. We will be here again next Friday at 1 p.m. Eastern Time with a special guest, author and preemie mom, Maureen Lim, and she's going to be talking about owning your story. Hope to see you there.